Alright, so most of you might know me already. I'm Roshan, Banjara. I'm an orthopedic registrar here. I worked here as a clinical fellow for 6 months in sarcoma. So let's just start with an example case. So this is an 11-year-old boy who presented to the accident and emergency with pain over the right upper leg since the last 5 months, and when the X-ray was done, the X-ray showed this. These are the X-rays that were done for the knee. So can anyone of you just tell me what is the most likely, what you can see, and what could be the most likely diagnosis? I mean, for making it easier for you,
I would guess.
So you tell you that there is a lesion at the center of the proximal tibia. Can you see that black shadow in there?
Yep.
We don't have a pointer here, yeah? This is the lesion that we can see here, right?
Okay.
If you see on the lateral view, this is the lesion that's there.
Yep.
So can any of you guys tell me what this could be possibly? Without, I have the options, like, and multiple choice options as well, but before that.
I would guess Ewing sarcoma.
Okay. Ewing sarcoma, okay. Anybody else?
Idealistic. It's an osteolytic lesion, reduces, and at the end of the lung bone, so it could be Ewing.
Could be Ewing.
So our options are osteochondrium, osteosarcoma. I'm not sure after the difference between them.
Frank? Any guesses?
I've heard the term
Okay, now I will give you the
not
options
sure
here. So most of you guys have told me that it could be Ewing sarcoma. You said it could be osteochondroma or osteosarcoma as well. So you've given me two diagnoses that are completely polar opposites.
Yeah, well,
One is
I've heard the terms, but I don't know what
and the other is completely, I mean, it's malignant, so
Yeah.
two ends of the spectrum, right? So now I'll give you the options. So now what could it be?
Never mind.
So Ewing sarcoma is not there?
Yeah.
Yeah.
Osteosarcoma.
Okay. So can you carefully look at the question again? So it's an 11-year-old boy who's presented with pain over the right upper leg since the last 5 months. Yeah. 5 months for bone tumors is a long duration.
Yeah.
A long duration means that the chances of this being a malignant tumor is they are less. So it's most probably a benign tumor. So we can eliminate chondrosarcoma and osteosarcoma and clear cell sarcoma from there. So it's between chondroblastoma and
GCT is
giant cell tumor. It's a classic teaching actually. So if this patient was beyond skeletal maturity, the diagnosis would be completely different. But since this child is an 11-year-old boy, and you can see the growth plate is still there, so it hasn't yet attained skeletal maturity. So that makes it easy for us to finally arrive to our diagnosis. We have something popping up here, huh? Your licenses, something. Can you
Oh, sorry, yeah. Sorry.
I'll close it.
Just press on learn more.
Alright. So
Just press on it.
this is a chondroblastoma. Alright?
Yeah.
So with the amount of information given in the question itself, we can actually narrow down the list of differential diagnoses to 2 or 3. What we need is the A's and an X-ray. So with the information of the A's and the X-ray only, we can narrow down the list of differential diagnoses to just 2 or 3 conditions. Here, with that information, we could have narrowed down the list of differential diagnoses to only 2. Because it's a prolonged duration. The history is for 5 months, it's a prolonged duration in tumors already. And it's a skeletally immature child. Right? And it's in the, so we will come to that later, but it's in the terminal line of the bone. And that narrows down the differential diagnosis to only 2 conditions, giant cell tumor and chondroblastoma. And since the child is skeletally immature, the diagnosis is a chondroblastoma. kept it that way. It's an interesting observation. So, like there are, I think, 15 or 16 tertiary centers for soft tissue tumors in the United Kingdom, but only 5 tertiary centers for bone, which deal with bone tumors. Yeah, and if you adjust, if you see at the incidence rate, it's almost 1 per 100,000 persons. That it is so rare to have a bone tumor. Yeah. Okay, and then let's go to the classification. This is the classic simplified classification: benign, intermediate, and malignant. So benign means that it's a slow-growing tumor, doesn't cause much of bone destruction or functional limitation, doesn't spread elsewhere. And intermediate means that it's a little more aggressive than the benign tumors, but then again it's not like that it spreads. It usually doesn't have distant metastasis except a few conditions. While in malignant tumors, they are quite aggressive. They cause a lot of destruction of the bone locally, and they have distant metastasis as well. And they also pose a risk to life because of the same reason that they are metastatic. So this is the general classification that we have for bone tumors. They can be benign, intermediate. Intermediate bone tumors are also called locally aggressive bone tumors. Can anybody tell me a classic example of an intermediate bone tumor? Intermediate or locally aggressive bone tumor? A classic example.
Giant cell tumor?
Yeah. Giant cell tumor is a classic example of a locally aggressive bone tumor, and malignant tumors. Can you name 3 very common malignant bone tumors that you guys might have come across, heard somewhere, read about it somewhere? 3. Can you name 3 malignant bone? Osteosarcoma, yeah, that's the most common. Yeah. Chondrosarcoma and Ewing sarcoma. Yeah. Those 3 are the most common bone tumors that we usually come across. And even in the malignant tumors, we have something called a primary malignant tumor that arises in the bone of concern, like it arises in the distal femur from the beginning. But if it is metastatic, it is coming from elsewhere, like from there is a lung cancer and it has metastasized to the distal femur. This is one classification, and the other one is this is another way of classifying the malignant bone tumors. It could be primary or it could be secondary. So by de novo or primary means that there was nothing in the distal femur before, and the tumor has developed there. But by secondary, what we mean by secondary is that there was something already there in the distal femur, and now it has converted into a malignancy. So can you guys guess of any condition that might turn into a malignant bone tumor while being benign in the beginning? Any condition at all? Do you know of any benign bone tumors? Can you name any benign bone tumors?
Osteochondroma?
Osteochondroma, yeah. Can it convert into a malignancy?
It was very low risk or no risk
Yeah,
at all.
it depends on a lot of factors, but if there is an osteochondroma, a solitary osteochondroma in the distal femur, there is 1% chance that it can convert to a malignancy. So if it converts into a malignancy, it usually converts into a chondrosarcoma, but then that chondrosarcoma would be called a secondary malignant tumor. Yeah? But if the chondrosarcoma were to arise without having any pre-existing condition, then it would be a de novo or primary. So we have 2 different types of classification for malignant tumors, and then we have this WHO classification of the tumors, 9 different groups, and all of them are on the basis of the origin of the tumor, whether it's chondrogenic, osteogenic, fibrogenic, vascular tumors, and all of them are again divided, expanded to include more tumors, and it's like a very comprehensive classification that includes almost all of the bone tumors that you can think of. So we can expand all of this into different other tumors. So all of them are again divided into the simplified classification that we discussed in the beginning: benign, intermediate, and malignant. So benign osteogenic tumors could be osteoma and osteoblastoma, and intermediate osteogenic tumors could be an osteoblastoma, and then in malignant we have the conventional osteosarcoma, but osteosarcoma itself has many different types. This is the WSO classification of osteosarcoma itself. And I mean, you don't need to have, I don't want to give you a lot of information to confuse you, but here you can see that in the osteogenic tumors, what conditions you will come across most commonly is osteoblastoma, osteoblastoma, and conventional osteosarcoma. Yeah. Similarly, if you go to the chondrogenic tumors, we have enchondroma, osteochondroma, chondroblastoma, chondromixed fibroma, and I think you have heard of all of these conditions, while the rest of the conditions listed may not be familiar to you. Yeah. And then in the malignant counterpart, we have the chondrosarcoma. Right. Similarly, if we go to the other tumors, in fibrogenic tumors, these are, I mean, very rare tumors, and we might not come across these tumors. Some surgeons may not come across these tumors in their entire practice as well. They are so rare. In the vascular tumors, we have the benign condition as hemangioma, and the malignant condition is angiosarcoma. Yeah, these are commonly encountered, and there is a separate classification for giant cell tumors, in which we classify them again into benign, intermediate, and malignant. Right? And in the benign tumors, there are aneurysmal bone cyst and non-ossifying fibroma. The most important feature of these giant cell tumors is that they have something called giant cells on histology when doing histology. What they have is a giant cell tumor. Yeah, giant cells in the histology. They have two components. One is the stromal component, that is the connective tissue, and they have the cells which are the giant cells, which, I mean, you guys must know mononuclear giant cells, if you can recall your pathology, knowledge of pathology. So they are characteristically found in these tumors. So that's why they are called giant cell rich tumors. And again, giant cell tumor is the classic example of this. But it's normally it's a locally aggressive bone tumor, and its benign counterpart could be non-ossifying fibroma or an aneurysmal bone cyst. But again, this giant cell tumor can be malignant as well. Yeah. So if you can recall, I told you that we can divide from malignant tumors into de novo malignant tumors, or primary malignant tumors, or secondary malignant tumors. So in giant cell tumors, it has been observed that sometimes a giant cell tumor which was initially just locally aggressive form or intermediate grade tumor can later convert to secondary malignancy. That is more common in giant cell tumors than having a de novo malignant giant cell tumor, which is very, very rare. Alright? So then we have the notochordal tumors. I think you guys might have heard of chordoma. Yeah, we don't have any intermediate notochordal tumors. So then there are other mesenchymal tumors, which includes the simple bone cyst and fibrous dysplasia. And the malignant counterpart is adamantinoma of the long bones. Can any of you guys tell me which is the classic site in the body where adamantinoma is found? It's like if we find a tumor that looks like a malignancy in that particular location, and we always think of this diagnosis first.
The humorous.
No. Anybody else? So it's the proximal tibia, and it's usually cortex-based lesion, but malignant. And if we find any aggressive lesion in the proximal tibia, we have to think of adamantinoma. Yeah, it's like the classic location, and there is something called undifferentiated pleomorphic sarcoma. Yeah. So, like I told you, in bone tumor, we have connective tissue, stroma, and different types of cells, and they could be fibroblastic cells, chondroblastic cells, or osteogenic cells. And if we do not have differentiation in any of those lines, or we do not have any dominant cell type, then we divide these into undifferentiated pleomorphic sarcoma. Yeah. So it's like a diagnosis of exclusion. If we cannot classify it as an osteogenic tumor, or as a chondroblastic tumor, or fibroblastic tumor, then we tend to give this diagnosis. to the tumor. Yeah. So I mean, you don't need to know all these in details, but I believe that you guys must have come across these names. I have highlighted only those conditions which are fairly common. So another thing is the hematopoietic neoplasms. You might have heard about plasmacytoma. It's a form of multiple myeloma, but it is called a plasmacytoma only when it involves a single particular bone. Yeah. And then we have Langerhans cell histiocytosis. We have different forms of Langerhans cell histiocytosis. It can be an isolated condition or it can be diffuse. Yeah. So Ewing sarcoma is placed under the group undifferentiated small round cell tumor. There is a classic Ewing sarcoma, and then there are round cell tumors which have different other genetic basis of pathogenesis. There are gene rearrangements and gene fusions, and based on that we have different other conditions. But the classic round cell tumor is the Ewing sarcoma. So coming to the clinical features, so basically bone tumors usually present with swelling followed by pain. Almost all of the bone tumors, and it's like the classic way of presentation. Some benign bone tumors may be asymptomatic, may be detected incidentally. Can you guys recall any benign bone tumor that is detected incidentally many times, mostly in children? So, but it's asymptomatic the whole time, and it has been detected. It is detected incidentally. And as the tumor grows, there are pressure symptoms developing. We might have neural, due to the involvement of nerves or vessels, we might have different symptoms. And if the tumor is metastatic, we will have systemic features. So what is the most common location for metastasis of bone tumors, malignant bone tumors?
The lungs.
Yeah, lungs. Lungs are the most common sites. So, and when there are pulmonary metastasis, it's hemoptysis, which is the more common symptom, or the patient can have cough, chest pain, shortness of breath, all those symptoms. And loss of appetite and weight loss are the constitutional symptoms when the patient develops metastasis, right? And if we have to differentiate between benign and malignant in terms of clinical features, as I told you already, there is a protracted course for benign tumors. They are slow growing, while malignant tumors are rapidly growing, and they usually grow to a large size. And when they grow to a large size, there is dilatation of veins around it, and they have tender erythematous. There is local wound as well. All the features of inflammation can be seen. And benign tumors don't usually have systemic features, and they are mostly asymptomatic. And if they have pain, it's mechanical pain, which is brought about by activity most of the time. But this is an important difference as well. But with malignant tumors, the patients usually have rest pain, which is worsened by activity. So even at rest, the patients have pain if it is a malignancy. All right.
Can I
So
just
sometimes,
ask, sorry, can I ask, you said earlier that 5 months was a slow growing one.
yeah,
Right.
yeah.
What kind of time scale would you be thinking this is more likely to malignant?
Yeah, if it is more than 3 months, we usually take it as a protracted course. Less than sometimes even within weeks, the malignant. There are certain tumors which grow to a huge size within weeks as well. So if it is more than 3 months, you can consider it to be a protracted course. These benign tumors can be there without any change in size for many years as well. Yeah, I'm not going to discuss every individual tumor because it will take quite a lot of time, because I'm trying to give you an overview of treatment as well, diagnosis as well. So it might take a lot of time. But if you want, I can discuss about. I haven't included the X-rays and all, but I can discuss about all the tumors if you want me to. So, and sometimes you just cannot miss the tumors. These are the late presentations. So these are the patients I encountered while I was working in India. So this patient had definitely they present late because of the poor referral system there. And you can see that there is dilatation of vein on the tumor there. We can find it even if the tumor is not that enormous. All the tumor with adequate margins later on. Before patients with pathological fractures, they used to be considered for amputation straight away because of the risk of contamination. But nowadays, with good chemotherapy, what happens is that all the hematoma is resolved and the fracture also unites most of the time, and then they can be considered for resection like other patients who do not have pathological fractures. But still, there is some problem. Still, the prognosis is not as good as those without pathological fractures. Yeah. So, in terms of imaging, plate radiograph is very, very important. Like I told you in the beginning, with just two information, age and location in the bone, we can tell what the diagnosis could be. So it's very crucial in diagnosis. Yeah? So before moving on, can you tell me what this thing, what this structure here is on that part of the bone?
The growth plate.
Yeah, that's the growth plate or the epiphyseal plate. And what is this? Okay, so by this I mean the whole portion of the bone here. What is it called? The epiphysis. It's the terminal end of the bone, yeah? Distal to the growth plate. This is the epiphysis. Which part of the bone is this? Metaphysis. And this is the diaphysis. So metaphysis is the cartilaginous part of the bone that grows while the bone is still growing, and diaphysis is the profuse shaft. Yeah. And metaphysis is considered to be the transitional zone or the junction between the epiphysis and the diaphysis. I'll just come to why this thing is important. So this is the longitudinal. We are naming different parts of the bone in a longitudinal plane, and there is another thing where we can name different parts of the bone in a transverse plane from the lateral to medial. There is the periosteum, the lining of the bone, and then there is the cortex. Then there is the endosteum, that is the inner part of the bone. If you look at it from the intramedullary portion, and then there is the medullary cavity. If you combine the information of age and where the tumor is in terms of longitudinal as well as transverse planes, we pretty much arrive at a very, very narrow list of differential diagnoses. So this is very, very important for us to know the different parts of the bone in longitudinal and transverse plane. Yeah. So this is, I think you guys must have come across this figure once or many, many times in your life. Yeah. With this diagram, there is, almost every diagnosis is here. So this is the epiphyseal portion of the bone, and having a tumor in the epiphyseal portion, we have just a giant cell tumor at the diagnosis. It's a giant cell tumor. Yeah? But if it is just in the epiphysis, central, yeah? And where in the bone? The longitudinal and the transverse plane that we discussed. Either the cortex, periosteum, endosteum, or the intramedullary cavity is involved, and whether the epiphysis, metaphysis, or the diaphysis is involved. Yeah? And the other thing is the nature of the lesion. So it could either be lytic, sclerotic, or mixed. So you guys must have come across this while you're studying about different types of metastasis, maybe bone metastasis, like prostate cancers have most of the time sclerotic metastasis, and thyroid or lung cancers have lytic metastasis. But then most of the tumors, they are mostly mixed. They have some lytic component as well and some sclerotic component as well, but not all the time. That's why we need to know whether it is a lytic, mixed, or sclerotic lesion. And then the zone of transition is very important for us to determine whether the lesion could be malignant or benign. So, do any of you guys know what the zone of transition is? So, if there is a tumor there in the bone, and you can make out easily where the tumor ends and the normal bone starts, that is called a narrow zone of transition. So we have a narrow zone of transition and a wide zone of transition. So if there is a narrow zone of transition, it implies that the tumor is benign. But if you cannot make out where the tumor ends and the normal bone starts, then it is suggestive of the aggressive nature of the lesion. It's eating up the bone rapidly, and you cannot make out easily where the normal bone starts. So it's called a wide zone of transition, and it is a very important feature of a malignant bone tumor. So narrow zone of transition, benign tumor; wide zone of transition, it's a malignant tumor. Yeah. And the other thing is the morphology of lesion. We will discuss this later. Morphology, matrix, and various reaction. We'll come to that later. And cortical involvement. If it is a very aggressive tumor, it will definitely either thin out the cortex or it will just come out of the cortex. Yeah, if it is very aggressive. And the other thing is, if it's coming out of the cortex, there is extra osseous extension and involvement of the soft tissue. And sometimes size can also be an important factor. Not in very aggressive malignant tumors, it does not matter, but like in benign tumors, in as an example, I can tell you that if it is less than 1.5 centimeters, it's an osteocostoma, and if it is more than 1.5 centimeters, it's an osteoblastoma. Like, the size is not very important in most of the conditions, but sometimes it may be helpful in differential diagnosis. Yeah. So coming to morphology of the lesion, do you have any idea what morphology of the lesion would mean? So you have a bone tumor, there is an area of lesions, and you just look at how the shape of it is, and you can see that it looks like an island to me, something like that. So it's giving you an impression of pattern. Yeah. If it is giving you an impression that there is a definite area looking like a geographical structure, then it's a geographic, that the tumor has a geographic pattern on the X-ray. Yeah. And so it's divided into geographic, moth-eaten, and permeative. Yeah. There is Logwick. There is the classification for different patterns of the tumor. So if we have a well-defined tumor and the margins are sclerotic, it means that the body is able to contain the tumor by forming a zone of sclerosis around it, and it implies that the tumor is benign. But as we go further, if there is no zone of sclerosis, body is not being able to contain the tumor, and then as it becomes more aggressive, there is irregular margin. It's still geographic, but the margins are irregular. And the moth-eaten and permeative are the most aggressive types of lytic lesions, where, there are uniform lytic lesions spreading all over the bone, all over the medullary cavity. And it is said but sometimes people give this distinction that by permeative pattern there is a uniform small lytic lesions, while in moth-eaten there is not. But that is not very important. Permeative is the most aggressive form, most aggressive pattern of bone destruction or bone disease. Alright? And coming to the matrix. So the matrix means the way the lesion looks on the X-ray, we can make out what kind of tissue it could be. So, like I told you in the beginning, what are the three major types of cells or tissue that could be found on a bone tumor? Matrix. If you look at this new bone formation, it's looking like a cloud. So if it is a cloud-like opacity there, then we call it to be an osseous matrix. Okay? And the other one is a convoid matrix. So if there are cloud-like lesions suggesting new bone formation that are representative of osseous matrix, osseous tissue, and it is suggestive of osteosarcoma rather than a chondrosarcoma. Similarly, if the matrix is so that it looks like popcorn calcification there, rings and up calcification, it is typical of a convoid lesion or cartilaginous lesion, and it points more towards the chondrosarcoma. Yeah? And the other one is, sometimes we cannot make out what kind of tissue it could be. There is no discernible matrix there. And this is typical, again, of giant cell tumor. Giant cell tumors usually do not have any matrix because a the extensive lysis that is there. Yeah. So matrix is also an important information that you need to gather from the radiograph. Yeah. Then there is a periosteal reaction. Can you tell me what the white arrow is pointing at there?
Periosteal elevation.
Yeah, it's a periosteal elevation, but there is another term for it, which is quite commonly used to denote a periosteal reaction of that sort. If you look at it, it's causing the elevation of the periosteum, and the shape of it looks like a triangle. So it's
Called a triangle?
Yeah. So it's a triangular elevation of the periosteum caused by the rapid growth of the tumor. Yeah. And periosteal reaction, the main thing that we need to know about is that if it is a continuous solid periosteal reaction, it denotes that the tumor could be benign. But if it's an interrupted type of periosteal reaction like we are saying here, then it denotes rather it could be a malignant tumor. Yeah. So the white star is, I think I just made a mistake there. The white star is an interrupted periosteal reaction, and the white arrow is the Coleman triangle. All right. So again, we come across this, like Chick had said, this is a sunburst type of periosteal reaction, which is typical of osteosarcoma, right? And then there is, we just need to know whether the patient is skeletally mature or not. And we cannot see any growth plate here.
Yeah.
The patient is skeletally mature. Yeah. So what all information, can anybody just tell me what all information that you can just gather from this X-ray?
Well, it's an X-ray of the left head, proximal femur with the.
Yeah. So which bone? It's proximal femur. So which part of the bone? In terms of longitudinal and transverse plane classification that we just discussed, which part of the bone is involved?
Metaphysis.
Yeah, metaphysis. And in the transverse plane, you can make out that there is a lesion within the intramedullary cavity. So it's an intramedullary lesion. Yeah. So we can just forget all those cortex-based lesions now. Yeah. What other information that after we have told that proximal femur is involved, metaphysis is involved, and it's an intramedullary lesion, what other information we can gather from this X-ray? The nature of the lesion? What kind of lesion is it? So what kind of lesion is it? So either it can be sclerotic or mixed, right? So what kind of lesion?
Sclerotic.
Sorry?
The sclerotic.
Yeah, but it's sclerotic, but if you look at it closely, there are some areas of lysis as well.
Oh.
That's how most of the tumors are. They're usually mixed. They're usually mixed. So it's a mixed type of lesion. And then any other information? One very important information that you need to gather to deduce whether it is malignant or benign. It's very, very important. Whether you can make out where the normal bone is starting.
Not really, no.
We cannot make out. So the zone of transition, yeah. So the zone of transition here is white. So it has got white zone of transition. Anything else? Coming to morphology and matrix. What kind of morphology is? So is there a pattern here? Can you make out if there is a fixed definite pattern like a geographic pattern? You really cannot. Or you can say that it is geographic pattern without any defined margins. Yeah, you can say it either way. The morphology and the matrix. Can you make note of these areas of classification here? So what kind of matrix? Let's practice it once again. Yeah. Does anyone wants to give it a go? From start or finish? Yeah.
Is this going in the epiphysis and
So first of all, which bone of the body?
the radius?
Distal
Yeah.
radius.
Which distal radius,
Just
right?
the radius, yeah.
Yeah. So now you can say which part of the bone in terms of longitudinal as well as the transverse plane.
Spongy bone?
Yeah. Yeah, but so it's epiphyseous.
Yeah.
Is it involving only the epiphysis if you see it clearly?
And metastasis. So.
Yeah, and metaphysis. And it's like intramedullary, isn't it? Rather than, so spongy bone is a different thing because it's an end of the bone, but you have to define it in terms of whether it is in the periosteum, in the cortex, endosteum, or the intra, so it's in the intramedullary cavity. Anything else? So I can help you. So,
Yeah.
so what kind of lesion is it? Is it a lytic lesion? Sclerotic? It's a lytic lesion. And then what, in terms of zone of transition, can we make out where the normal bone is starting? Yeah? It's not like very, very clear, but there definitely is a zone of transition where we can make out where the normal bone is starting. Yeah? So this has a narrow zone of transition. Yeah? In terms of morphology, it looks geographic, isn't it? But the margins are not sclerotic. Yeah? The margins are not sclerotic, but it is definitely geographic. Yeah? And we discussed the matrix. No. What matrix does it have? What kind of matrix does it have? Lytic, rather than lytic, you cannot actually make out. No, lytic is not the matrix that we do. The matrix is either fibrous, osseous, conduit, or no matrix at all. So if you look at it clearly, do you think it's like a particular type of matrix? No. So we cannot make out what kind of matrix it is. It's completely, the bone is eternal completely. Yeah? It's completely lytic. So any other things that you're missing? We discussed the matrix as well. And
No periosteal reaction.
yeah, no periosteal reaction. That is also typical of this condition. Anything else? So if you see, the cortex has been bridged here. If you look at it closely, there is a slight bridge in the cortex, and you can see there are some soft tissue component as well. Yeah. Anything else? I think we have covered pretty much everything. So this again, same things. So distal radius, epiphysis, we can say it is epiphyseal, metaphyseal, intramedullary, lytic lesion with narrow zone of transition, geographic morphology, without sclerotic margins, no discernible matrix, and there is thinning of cortex, and we can say that there is some destruction of the cortex as well. So this is going to be giant cell tumor of the distal radius unless there is something in the final biopsy region. So this is going to be. These are the typical radiographic features of giant cell tumor. Yeah. So just looking at the X-ray and just simple clinical information, you can narrow this down. If I tell you that the growth plate hasn't fused yet in this patient, what would we be thinking of instead of giant cell tumor?
In control? It won't look like that exactly.
No, not in control. So while it is growing, the central part of the tumor is already dead, necrotic. Because body cannot keep up with the rapid growth. New vessels are forming on the growing edge of the bone, and they are not being able to supply to the central part of the bone, so it dies. It's necrotic. It's not representative sample. If you get a necrotic sample, then again the pathologist has every right to tell you that you didn't do your biopsy properly. All right. So always, whenever possible, you take a sample from the periphery. Yeah. And whenever you make a hole in the bone, it has to be a round or oval bone, because it is said that the stress concentration is uniform if the hole is oval. If you try to make it square or uneven, stress concentration is not uniform, and what it may cause is a fracture. So you have to make sure that the hole is round or oval. Okay. So somebody has done a biopsy here. Has it been done properly? Somebody has taken a sample from the proximal femur going to the lateral cortex. Can you say that it has been done properly? Somebody has hacked onto the bone, isn't it? They have taken samples. They have been quite desperate in taking out samples from the bone. They have eaten up the bone, you can say that. They have taken out a chunk of the bone from there. So ideally, it shows on the X-ray if you have made an oval opening and gone straight, it shows on the X-ray that you have made a good track. So what might have happened here? The bone, there is a chance that the bone fractures,
Actually, yeah.
and that is what has happened in this case.
Mm.
So by looking at these two pictures, can you tell me what's wrong in these biopsies, or is there not anything wrong? Has everything been done correctly? So biopsy has been taken from here in this case and from here in this case. What structure can you find here and there as well?
Patella extensor.
Patellar tendon?
Extensor mechanism.
Yeah. So somebody has taken all his hard efforts to disrupt the patellar tendon. They have contaminated the patellar tendon.
Oh.
So the implication of this is that when we remove the tumor in the final surgery, the patient is not going to have any extension of the knee, because the basic principle of the surgery in tumors is to remove all of the tumor that you can with good margin. So you have to remove the whole patellar tendon because there is tumor in it already. So we have to fuse his knee just because someone contaminated the patellar tendon. There is not going to be any movement. We have to do arthrodesis of the knee. We cannot give any extension mechanism to the patient. Similarly, it's the quadriceps tendon that has been contaminated. Yeah, in the other picture, and it's quite an old study, but Mankin et al. In 1982 reported change in optimal treatment plan in 18% and unnecessary amputation in 4.5% of the patients just because of improper biopsies. Yeah, so biopsy is very, very important. You need to know how biopsy should be done, how proper biopsy is done. Now we come to staging. So what do we mean by staging? How much of the tumor has spread locally as well as whether it has spread to other parts of the body. So in bone tumors, it usually spreads to the lungs, followed by bones, followed by other bones, and then sometimes there are metastases to other fissure regions as well, but they are very rare. Yeah. So what is the importance of staging? What can it help you with? I think it's already there. But determination of prognosis, right? If it is an advanced stage tumor, it's definitely going to be a worse prognosis for the patient. Anything else? So once you know the prognosis, how does it help you? You can counsel the patient, yeah, but how does it help you in other ways? Can it help in your treatment decision making? What kind of treatment you are going to
how
give?
urgent needs to put theatre.
Yeah. So in advanced stages of bone tumors, there are two types of intent of treatment which is important. Either it is palliative or it is curative. If it is already an advanced bone tumor, then the intent of treatment is going to be palliative. And if it is not in advanced stage, the intent of treatment is going to be curative. So it helps in treatment decision making. So we have different system of staging. Innate system of staging is now mostly, that's why we always get a chest CT scan done. Yeah? Is it enough for staging? Is a chest CT scan enough for staging of a bone tumor?
It's not enough.
It's not enough. Why is it not enough? Because we have skeletal metastasis as well, so we need to do a bone scan to know if there are any skeletal metastasis. Is it enough now?
I think it's sufficient.
Yeah, it's actually more than enough. That it covers everything now. But there is something called 18F FDG PET CT scan. Do we need to do this? Do we have this everywhere?
No.
No. We have this only in tertiary centers. Even in tertiary centers, not all of them have this facility. Yeah? And if it is not required, why do we get it done? It's not going to give you any further information. But if somebody is going to do it, it can replace both the chest CT scan and the bone scan. Is it true? Can it replace chest CT scan?
No, because Yeah, you get soft tissue as well.
Yeah, I mean, it may not be necessary for you to know, but they say that the slices that they make on a chest CT scan are quite thin, that they can detect metastatic lesions as small as less than a centimeter, but that is not possible with a PET CT scan. So a PET CT scan may actually miss success of pulmonary metastasis. Yeah. So getting a chest CT scan and a bone scan is more than enough, but you cannot always bank on just a PET CT scan to rule out pulmonary metastasis. Yeah. And in chondrosarcoma, skeletal metastases are so rare that we don't need to get a bone scan done. Just a chest CT scan is enough for a chondrosarcoma or a chondroid malignant tumor. Yeah. So coming to treatment, it's a multidisciplinary approach. We always have MDT all the time. You guys know it. So it involves everyone in the hospital. No, it's not treated only by the orthopedic surgeon or the medical oncologist. We need to involve everyone in the radiologist, the physiotherapist, the pathologist, cancer specialist, nurses. They have a very important role. Rehabilitation specialists, social workers. So it's a teamwork. And in benign tumors, do you guys know any treatment modality? Are you guys aware of any treatment modality for benign bone tumors? You have a simple bone cyst. A child comes, a mother brings a child to you. You get saying that they feel that they have broken the bone in the proximal humerus. You get an X-ray done. There is a lytic lesion in addition to the fracture. And you look at it, you feel that it's benign because it's well-defined lytic lesion in the proximal humerus with a fracture in it. And by the radiographic features, you come to a diagnosis of a simple bone cyst. What do you do?
We need to fix that fracture. First, we
Is
go-
it necessary to fix that fracture?
Not really. no.
Yeah, not really. So it is said that having a pathological fracture, it's painful to the child, it's stressful to the mother, but it's a treatment for the simple bone cyst. It is said that in the pathogenesis, there is an increase in venous pressure within the bone, because of which there is an influx of inflammatory cells and they lead to lysis of the bone. And having a fracture, the whole pressure goes away. The pressure is relieved, and it is an important step towards healing of the fracture itself. And it's the relief in pressure rather than the inflammatory steroid that does the trick, leading to healing of the lesion. Yeah? And for aneurysmal bone cyst, also there is the sclerotherapy, but it's not a steroid. It's a different sclerosing agent, and here it needs the different sclerosing agent rather than the steroid. And for osteoblastoma, you might have heard what is called a radiofrequency ablation. What is done is that we point under the guidance of CT scan, we locate that nidus of the osteoblastoma and we burn it. It's as simple as this. We burn it, we take the temperature to around 75 to 80 degrees Celsius for that particular region of interest, and we burn it. And that's it. It leads to resolution of that lesion. All right. And the other thing is, for giant cell tumor of bone, most of the time, if it has not extended beyond the cortex into the soft tissue, most of the time what we do is curate us. And for any other benign reason that is not responding to the usual treatment, like if the aneurysmal bone cyst and simple bone cyst is not responding to injection sclerotherapy, or an osteoblastoma is not responding to radiofrequency ablation, whatever benign tumors not responding to the usual treatment, we move ahead with the curitas, which is most commonly performed for the giant cell tumor of the bone. That's how we do it. We just take a window, we create a cavity, and it is said that we create a cavity as big as the tumor itself, so that we can scoop out all the contents. And we try to make it as thorough as we can to reduce the chance of recurrence. Yeah. Let's not go in detail about the principles of curitas, but that's how we treat the benign bone tumors. Yeah. And malignant bone tumors. What's the basic principle of treating malignant bone tumors? What do they need?
Excision margins.
No, that's starting the treatment.
Oh.
You have a child who has been now diagnosed with osteosarcoma of the distal femur. What do you do now? Like, you are the only doctor that the child has met until now. What do? You got a biopsy done, and the biopsy has been now reported as osteosarcoma.
Right,
What's the next step?
MDT referral,
Yeah, MDT referral. Well, now, what would be the outcome?
chemotherapy.
So now the medical oncologist will take responsibility and start chemotherapy for the patient. So if the tumor is chemosensitive, this is the usual way it is treated. Start with a neoadjuvant chemotherapy. Do you understand what a neoadjuvant means?
Before
Before surgery is done, yeah. And adjuvant means after the surgery is done. So surgery is in between, sandwiched in between. Can we consider saving the limb? Can we consider not doing an amputation? So not doing limb salvage means you are saving the limb, right? So it's a set of surgical procedures that are designed to accomplish. So you have to remove the tumor, and at the same time you achieve acceptable oncologic, functional, and cosmetic results. Yeah. So the most important thing is it has to be acceptable to the patient. Yeah. You cannot say that I'm a great surgeon, I'm going to save your limb, and patient cannot be like after the surgery, patient is dissatisfied with the outcome. It cannot be so. Patient has to accept the limb that has been saved for him, yeah? And it has to be functionally at least as good as or better than before surgery. Yeah? So this is an important rule that we usually employ in deciding whether the patient has to go for amputation or not. If three of these are involved, bone, nerves, vessels, and soft tissue involved, if any three of these are involved, then limb salvage is probably not worth considering. Yeah? Okay, so while we do surgical resection, we consider surgical margins. This is a very important concept. There are 4 different types of surgical margins. Okay, so can anyone tell me what would an intralesional margin? Everything is there. Just look at the diagrams and tell me what an intralesional margin would mean.
going through the lesion.
Yeah. So you enter the lesion. Okay. Intralesional means you enter the lesion. Marginal means you just go around the margin. You don't go into the lesion. Wide resection means wide margin means you take a normal cup of tissue around. You just don't reach the margin or inside the tumor. You just take a normal cup of tissue along with the tumor. You do not go into the tumor or the margin of the tumor at all. And radical margin means that along with the normal cup of tissue, you are taking the whole compartment that has been involved by the tumor. So does radical resection always mean amputation? Would radical resection always mean amputation?
No.
So if the whole anterior compartment of the thigh is involved, we just remove the anterior compartment and we do some flap surgery for coverage. It's a radical resection, but we are not amputating the limb. So we have to understand that radical resection doesn't always mean amputation. Yeah? So for extensive involvement of the soft bone and soft tissue, we need to sometimes go for radical resection. Yeah? So can you tell me what tumors can be considered for an intralesional resection, like we just discussed earlier? I may not have gone in great detail with that thing, but
So the osteoma where you just get the nidus.
yeah, we get into the tumor. A better example would be GCT, giant cell tumor. Yeah?
Yeah.
We are just opening a window. We are going inside the tumor and we are scooping out the tumor. Yeah? So it's an intralesional margin for that tumor. It's an intralesional resection or curettage. Yeah. So what is the disadvantage of going intralesional?
You're breaching the body's defenses for this lesion and therefore helping its dissemination.
Okay, not body's defenses, but let's think of it as like a practical thing. You just open the tumor, and you have given a surgical incision. There are soft tissue open there. So, and giant cell tumor is a tumor that seeds. That has great tendency to seed onto the surfaces, the living surface. There are reports of giant cell tumor developing on the foot of the surgeon while doing the surgery, the giant cell tumor is spilled onto the ground, onto the foot of the surgeon, and then the surgeon had giant cell tumor there.
With index.
There are case reports. All right. So this is a very suitable tumor, and with intralesional resection, you tend to increase the chance of recurrence. There are many examples where a properly done curettage may not lead to any recurrence at all, but there is a high chance of recurrence with that. So if you remove the giant cell tumor with a wide margin, taking a normal of tissue around it, less chance of recurrence. But you cannot do that with a malignant bone tumor, can you? So it has to be wide resection all the time. You cannot take chance with a malignant tumor. You can take chance with giant cell tumor because the most it is going to do is destroy the bone around it. So it's a functional limitation. There is a chance of functional limitation, but no risk to life there. But with a malignant tumor, if you don't remove it completely with a wide margin, it's going to come back again, and it's going to increase the risk of metastasis if it was not. Can you tell me in what condition would we remove only half of the bone? It's like hemicortical resection. If it only involves the periosteum or only the cortex, like in a parosteal form of osteosarcoma, we can get away with only hemicortical resection and fixation with a graft or a plate onto that. Yeah? And then the other one is full segment resection. In full segment resection, there are two types of resections. If you look at this, we have spared the joint here. Yeah? And if you look at this, we have sacrificed the joint. These are the two types of resection that can happen around the joint. Depends on the tumor. So, if it is an ewing sarcoma and it's an early presentation, you've given the chemotherapy and all, it's going to be an intercalary. Intercalary means diaphysium. Yeah? It's going to be an intercalary resection. But if it is an osteosarcoma, it's metaphyseal, can extend to the epiphysis, sometimes may not be able to preserve the epiphysis, and we have to. So if you have to take wide margin, you have to take the cartilage with you, right? So you cannot preserve the joint in that case. So we either have a joint preserving surgery or a joint sacrificing surgery. Yeah. So you guys might be aware of what reconstruction method is commonly used when we sacrifice the joint. There is no joint there. There was a tumor there. Let's say there was a tumor here. Until this point, we remove the whole thing and we have a defect like this. How is it usually reconstructed? So there are, broadly, the reconstruction is classified into either biological or prosthetic, that means use of an endoprosthesis. You guys must have seen many endoprosthetic reconstructions being done here. Yeah? Proximal femoral endoprosthesis, distal femoral endoprosthesis.
Yep.
Even in metastatic cases, proximal femoral endoprosthesis is done in many tumors of the proximal femur, many metastatic tumors of the proximal femur. Yeah? So, in biological methods of reconstruction, what we use is, we either use an autograft or an allograft, or if you guys are aware of this concept or not, sterilized tumor bone. Have you heard of it?
You have to get the same bone, sterilize it by.
There are many methods of sterilization.
Yeah. And then putting it back in.
It's not done here, but where I practice in India, it's done there, and it's very, very popular in Japan. The use of liquid nitrogen to sterilize the tumor bone. They do it in almost all the cases. They're crazy about it. So, in biological methods, we have an autograft, allograft, or sterilized tumor bone, and then non-biological prosthetic is the use of endoprosthesis. Yeah? So in autograft, I'll just give you an example here. So this is an aggressive giant cell tumor of the distal radius. They resected the tumor and they used this. This is a fibula of the same patient. So it's an autograft, and they fused the joint. Yeah? And this concept might be a bit not up to your level, but whenever you have to do a biological reconstruction after sacrificing the joint, you cannot have any movement at the joint. Yeah? It has to be fused.
Is it not possible to correct a hinge prosthesis?
Yeah, you're getting it, and I'm happy that you are getting it. You cannot get any movement there. You have to fuse it, because if you try to do some fancy work and try to gain some wrist movement, it will eventually fail. There is going to be osteoarthritis there. Instead of doing it later, giving undue stress to the patient, just fuse it now at the primary surgery, index surgery, and the patient is not going to have too much of functional limitations. The patients are able to go on with the daily activities of living, activities of daily living. Even with a fused wrist joint, they are able to do many of the works that they were able to do before. But if you try to be brave and do some fancy surgical work and then try to salvage the wrist joint, it's going to fail eventually. Yeah? It's true for knee joint as well as the hip joint. If you use a biological method, you have to fuse. So whenever there is involvement of the joint and you are going to use a biological method of reconstruction, you fuse the joint. There are some cases where people have tried to salvage, but then again, there are no long-term studies. So it's like 1.5 to 2 years, there was a study from India in which a doctor tried to use a sterilized tumor bone in the acetabulum. They just took out the involved.
Structurally intact. No fit.
So if there is a pathological fracture or if there is an extensive lysis that the bone has almost melted, you cannot use this method. Yeah? And the other thing is, it cannot involve the joint. Like I told you, if it is involving a joint, you cannot use a biological method. This is a biological method of reconstruction. You cannot use it on a person who has just joint involved. You cannot just take the whole joint. If you take the tumor out from here, you cannot take the whole thing, the proximal tibia as well, with the cartilage, and then take it to the radiotherapy and irradiate it. The whole cartilage will be gone. Yeah. So it's definitely going to cause some arthritis. There is no use trying to put the whole thing back, including the joint, in these cases of biological reconstruction.